All right, let's dive right in. In this explainer, we're tackling two systems that are worlds apart in function, but are both absolutely critical for the vestibular system. First up, we've got the efferent network. Think of it as the brain's own remote control, constantly fine-tuning the inner ear sensitivity. And then we'll get into the vascular anatomy, a system with a really unforgiving all-or-nothing design that literally dictates the clinical footprint of any ischemic event. And just so you know, all the information we're about to go through comes straight from the Comprehensive Clinical Review on Vestibular Anatomy, a fantastic resource provided by Australian dizziness clinics. So to really get a handle on this, let's frame it this way. On one side, you have the efferent system. It's a subtle, modulating network that's all about adjusting gain and filtering out self-generated noise. It's the control network. On the other side, you've got the vascular system. This is pure life support. It's a terminal system, which means when there's a blockage, we're not talking about modulation anymore. We're talking about cell survival. It's that serious. Okay, so first, let's dig into that control network. The efferent vestibular system is basically the brain's direct line to the inner ear. It allows the central nervous system to actively dial the sensitivity of those peripheral sensors up or down. I mean, it's just a remarkable example of the brain controlling a sensory system from the top down. And, this pathway is incredibly direct. It all starts in a small group of neurons buried deep in the brainstem, right next to the abducens nucleus. From there, the axons shoot outwards, essentially piggybacking on the 8th cranial nerve, and travel directly to the labyrinth. And their targets are super precise. They synapse straight onto the type 2 hair cells and also onto the outer surface of that unique cup-like nerve ending, the calyx, that envelops the type 1 hair cells. So how does it actually work its magic? Well, the main neurotransmitter here is acetylcholine. And this is a cool paradox, unlike its usual job of getting things excited, here it acts on these special alpha-9/alpha-10 receptors that actually cause the hair cell to hyperpolarize. It effectively turns down the volume. So what's its primary job? It's all about gain control. When you decide to move, your brain sends out what's called an efference copy, basically a memo of the planned movement, to the efferent system, which then preemptively dampens the vestibular signal. This is literally why you don't get dizzy every single time you turn your head on purpose.
Okay, let's pivot now. We're moving from the subtle world of efferent control to the, brutal reality of the vascular supply. The single most important concept to grasp here is what we call the end artery problem.
This quote right here says it all, and it's probably the most crucial takeaway about inner ear ischemia. The entire membranous labyrinth is supplied by a single terminal vascular system with essentially no collateral circulation. Think about that. Unlike the brain, which has backup routes like the circle of Willis, the inner ear has zero backup. If that single supply line gets cut, the damage is immediate, and it's irreversible. And here it is, that single supply line. This is the labyrinthine artery, the absolute lifeline for the entire inner ear. You can see it almost always branches off the anterior inferior cerebellar artery, or AICA for short. It just peels off and heads straight into the internal auditory canal, right alongside the nerves. That's it. It's the one and only arterial road in. So once it's inside that canal, the labyrinthine artery splits. The first branch to know is the anterior vestibular artery, the AVA. It's the smaller of the branches, and its territory is a perfect mirror of the superior division of the vestibular nerve. It takes care of the utricle and the ampullae of both the anterior and lateral canals. Now, the other big branch is the common cochlear artery, which, no surprise, mainly supplies the cochlea. But it gives off a really critical branch for us, the posterior vestibular artery, or PVA. And just like the AVA, the PVA's territory perfectly maps to its corresponding nerve, the inferior division, supplying the saccule and the posterior canal ampulla. So why are we obsessing over this precise mapping? Because this is what lets us pinpoint lesions with incredible accuracy, just based on clinical signs. The specific pattern of what's working and what's not tells you exactly which blood vessel is probably blocked. This is really where the anatomy comes to life at the bedside. Let's just compare them side by side. If you have an AIC infarction, a blockage of that main trunk, you get sudden hearing loss and vestibular symptoms, plus those key brainstem signs like facial palsy and ataxia. Now compare that to a Wallenberg syndrome from a pica occlusion. You still get major brainstem signs, but notice this, the hearing is spared. And what if it's just the labyrinthine artery itself that gets blocked? You get a devastating blow to hearing and balance, but no other brainstem signs. You see how critical this distinction is for localization?
Which brings us to this really pivotal clinical question. You have a patient with vertigo and brainstem signs. Why is the presence or absence of hearing loss the absolute key to telling an AICA stroke apart from a PICA stroke? And the answer is just so elegantly simple. It all goes back to the anatomy we just covered. The labyrinthine artery, the one that feeds the cochlea and the vestibular system, is a branch of AICA. It is not in PICA's territory. So a PICA stroke spares hearing, but an AICA stroke can't. It's just a beautiful example of how vascular anatomy perfectly predicts the clinical syndrome. So let's boil all of this down into 3 practical, powerful rules of thumb that you can take away from this and start applying in your clinic right away. Rule number 1, never forget the end artery problem. No backup circulation means a blockage is catastrophic for whatever that artery supplies. Rule number 2, acute vertigo plus sudden hearing loss is a massive vascular red flag. It points you directly to an ischemic event in either the labyrinthine artery or the main AICA territory. And number 3, know your territories. Understanding that the AVA supplies the superior parts and the PVA supplies the inferior parts lets you connect the clinical signs directly back to the vascular lesion.
We have mapped the efferent system and vascular territories of the inner ear. Join me in our next explainer, Scarpa's ganglion, and the vestibular nuclear complex, where we will examine the topographic organization of Scarpa's ganglion, which directly explains why superior vestibular neuritis spares the saccule, and trace the 4 major vestibular nuclei, their eponyms, and the lesion syndromes produced when each is disrupted. Thank you for listening to this series. To explore more similar topics regarding dizziness, vertigo, and imbalance, and to get clinician and patient resource materials, visit AustralianDizzinessClinics.com. Please subscribe and leave a rating.